Karen, teach us all the things.
Cool. Well, thank you, everyone. Welcome to this talk. I have to have a disclosure that's not going to be all the things about hyperkalemia because they're so vast. Let me just see if I can get this going here. But we will be discussing largely drug-related hyperkalemia and those effects and pertinent questions. In terms of disclosures, none, like most of us. And learning objectives. So we are just going to go through how to put in that power plan in Orca. Remember to initiate it and click all the boxes. I'm just kidding. Orca's about to go away, so we'll learn how to do an epic. Just kidding about that too. We're mostly going to be going through medications that cause hyperkalemia. So there are other causes of hyperkalemia that are not related to medications, although I think you'll find that in practice, much of the time, medications are playing a role, even if there is something else causing or relating to the high potassium. We're going to talk about like what scenarios you're most likely to see iatrogenic hyperkalemia in your own clinical practice, mostly outpatient, but also a little bit of inpatient, and some strategies for managing that. We're not going to be discussing a lot of acute hyperkalemia management, and I'm going to go through a good number of drugs that are related to hyperkalemia, but it's not going to be all of them. There are many, many drugs, and we're just not going to have time for every single one of them, but we'll try to hit on the ones that you're most likely to see. If questions come up in the chat during this, if someone could just say them out loud, because I can't see that super well right now. So we're just going to talk, I know it was requested that we just talk about the normal range of what we consider potassium to be high, and that's actually not as easy of an answer as you might expect. Some places will say that greater than 5 is considered hyperkalemia. Some places will say greater than 5.5. In our system, it's 5.2, so that's what we'll go with. It's not necessarily dangerous to be greater than 5.2. We don't necessarily start seeing dangers until the higher 5s, low 6s range. But the number will turn red if you are in the UW system greater than 5.2. And in practice, the reason for hyperkalemia is oftentimes iatrogenic, and it's a pretty broad range of percentage, but it's estimated that between 35 to 75% of patients who are hospitalized have a drug as one of the primary causes of high potassium if they have high potassium. And a lot of medications that you are commonly prescribing, both outpatient and inpatient, are associated with hyperkalemia. And most of these, or oftentimes these medications are actually used together, and they are indicated together. And therefore you have to be careful about it and think about it when you're prescribing these medications and thinking about monitoring your patients. So in terms of why these drugs cause hyperkalemia, there's a few primary mechanisms. The middle one in this list is really the biggest one, but the first on this list is transmembrane potassium movement. So medications that cause the potassium in the cells to move out of the cells. The second is regarding the renin-aldosterone angiotensin system. So impairing potassium excretion at the renal level. It's usually through the inhibition of the RAS system in some way, either by inhibiting the axis or increasing the resistance to aldosterone at the tubule level. I know everyone loves renal physiology, and that was our favorite topic in medical school, so we'll talk about that a little bit more. And then the last category here, which is really not a very significant category, is potassium-containing drugs. Like I said, this is not a very high yield or common one, but it's just something to keep in mind. We'll touch on it briefly at the end. And so just to go through the aldosterone system, the RAS system, because this is really the driver in most of these cases. Aldosterone, if you might remember, is bound to the mineralocorticoid receptor in the distal tubule and principal cells in the cortical collecting duct. So that's at the end of the kidney. Also in the colon and sweat glands. And that activates the sodium-potassium ATPase, which increases the potassium concentration interluminally, and then it increases potassium excretion into the lumen through basically electrochemical gradients. And it stimulates the ENaC cell expression, which brings sodium back into the cells from the lumen and increases potassium excretion out into the urine. And this is just a little picture of that. So I can see here, this bottom represents the blood, the red, and the yellow represents the lumen, urine. So the aldosterone is binding to the mineralocorticoid receptor on the interstitial side, and that is driving the expression of the ENaC channel, which causes sodium to come in from the lumen. At the same time, it increases the expression of those ROM-K cells or channels, which drives potassium out. And on the interstitial side, you can see the sodium potassium pump is driving potassium in to allow it to then go out into the lumen and sodium back into the blood side. So essentially aldosterone causes, in a sense, the excretion of potassium into the urine. So when you're blocking aldosterone or the effects of aldosterone in any way, you're going to end up with more potassium in your blood. So we're going to go through some cases, a few cases here, and they're a little interactive. So if you all just unmute your microphones or put in the chat, and we'll go through them. And we're going to just work our way through a few medications that are probably the most, sorry, my dog is demanding attention. A few cases that are probably, or drugs that you're most commonly going to see in practice. So our first case is Mr. Len Tills. He's a 72-year-old man with diabetic nephropathy, hypertension, and HFrEF. He's presenting for follow-up of his blood pressure management. You increased his blood pressure medication a few weeks ago because it was above goal, and you recheck his labs today. So you can see the fishbone here. His old labs are on the top and his new labs are on the bottom. I didn't make any of these numbers red, so we'll require you to have a sense of the range of what is normal. But you can see his potassium is a bit high, his creatinine is a little higher than it was. So what do you think is going on with this particular case? Just increased his blood pressure meds a few days ago, or a few weeks ago. So you can see. Yes, I see increased his lisinopril in the chat. I also see Alex asking my dog to be on camera, maybe at the end. Yeah, so that's a great suggestion. And let's see if I can go through. So we're gonna look at his medication list. He's on metoprolol, glargine, Lispro, losartan, and furosemide. So increases lisinopril or increases losartan. Either one, they're fairly similar in this particular sense. So we're just going to talk a little bit about how these work. So ACE inhibitors and ARBs, these work by decreasing the aldosterone secretion, ultimately leads to decreased sodium delivery to the distal nephron, and inhibits the RAS pathway, which causes, as we discussed already, decreased potassium excretion. Now, when people have normal renal function, if you're really just using this for essential hypertension and they don't have any renal disease, the risk of hyperkalemia, like a true hyperkalemia, is actually quite low. There's been some very large trials, large randomized control trials that have been pooled that have shown that really a very small risk if it's just being used for uncomplicated hypertension. But as you all know, in reality, most of the time, or much of the time, this drug is being used, these drugs are being used for much more complicated patients who have baseline decreased renal function and heart failure and diabetes and are elderly, so they're at higher risk for the complications. And they're especially high risk for complications when they're being used with other drugs that affect potassium, which we'll be discussing. But a lot of these drugs are used in combination because that's how they're indicated. So in terms of a take home for ACEs and ARBs, they are actually pretty safe with normal renal function, but if you're starting an ARB or an ACE or titrating the dose, you should be rechecking your labs within a week or two, and then continuing to check the labs with each titration until you're at a stable dose, and then checking about every 6 to 12 months, depending on the patient. And this is just a nice graph or figure demonstrating this pathway and where the ACEs and ARBs are going. You can see in that red arrow, they work at a slightly different aspect of the pathway, but for intents purposes, it's pretty similar effect. You can see the nephron is the largest organ here, which is just illustrating its relative importance compared to the lung and the liver. And so what do you do next for this patient? So what happens a lot in clinical practice is you have patients on ACEs or ARBs, you check their labs, their potassium's getting high, it's scary, and you stop the drug, or you decrease the dose to something that's maybe not that functional. When patients have diabetes, especially proteinuric renal disease or heart failure, these drugs are both renal and cardioprotective and life prolonging. So what do you do if this is happening where a patient just can't tolerate RAS inhibition because of hyperkalemia? Does anyone have any thoughts of what you could do? Too much avocado toast, yes, seeing that. Okay. Well, fortunately, this is talk about hyperkalemia, so I have some options for you. So increases furosemide, that is a great thought. Let's see if I can move this through. Yeah, so as Lindsay said, you could try an increase in furosemide. Low potassium diet is also suggested. Actually very controversial whether low potassium diets are very good for these patients, and that's kind of a whole nother talk into itself. The main potassium that you get from food is potassium phosphate, and potassium chloride is oftentimes what will drive your potassium up. And renal diets are kind of falling a little bit out of vogue for these patients because they eliminate a lot of healthy food. But again, that's a whole nother topic. I'm seeing other suggestions here as well. Potassium, add another agent, decrease the dose, promote bowel motility. Those are all great thoughts. You can decrease the dose if you still have good blood pressure control at a lower dose, increases Lasix, or if he was on a thiazide diuretic, Mr. Tills here is not on a thiazide diuretic, that would be another option if you have room to add a thiazide. Bowel motility is also a great suggestion. Patients, especially with CKD, are very prone to hyperkalemia if they become constipated because they can't eliminate as much potassium renally. And then in terms of agents to lower potassium, we actually very excitingly in the last 5 to 6 years, so Potassium is, the brand name is Veltasa, and I see Lokelma suggested too. Yes, you all know all about this already. This is great. So Potassium is a resin polymer that exchanges calcium for potassium in the GI tract and the colon. So it increases fecal potassium excretion. And it has been quite successful. I think it was approved by the FDA like 6 or 7 years ago. It's a daily medication. It reduces the risk of hyperkalemia in patients with CKD with or without heart failure, and allows for the continuation of RAS inhibition in the majority of cases. We're seeing in large trials anywhere from 0.5 to 1.2 millimole reduction in potassium after about a month of using this. So it's quite successful, and as compared to Kxalate or SPS, just kind of the traditional oral potassium binder, which has a small risk of bowel necrosis, which I'm sure you've all are familiar with. But more importantly, it's actually very poorly tolerated. SPS's Potassium is much better tolerated. It's just easier to take for patients. And it does have some GI side effects, but not nearly to the degree of Kxalate. It is, however, expensive. It can cause hypomagnesemia because the exchange is not extremely specific. So you should be checking magnesium levels before you start this and making sure they're magnesium replete. Can have GI side effects. I did look up the Apple Health Medicaid drug list, and this is covered, or it's on the list for Medicaid. So if you're thinking of starting a patient on this, speak to your friendly clinical pharmacist about it, but it is certainly an option. And looking also at Medicare coverage, it's covered by about 50% of Medicare plans. I think the copays can be kind of high. So there is still some limitations to this drug in terms of cost, but certainly an option and something that you should be thinking about if you have a patient who you feel like you're being limited in your RAS inhibition by their potassium levels. And the other drug that has come out more recently, is called sodium zirconium cyclosilicate, or Lokelma. You've probably seen this in the hospital setting as well, although if you try to order it at Harborview, you will get paged that you're not allowed to. It's kind of reserved because it's so expensive. It works similarly. It's an oral potassium binder in the intestines, differently than the patiromer. This actually works a little earlier in the GI tract, so it lowers potassium more rapidly, even within a couple hours, and will oftentimes normalize potassium within 24 to 48 hours. And it maintains normal kalemia for most patients with CKD. So it's actually a really effective drug. And again, it's expensive, so there's still some limitations on its use. On the Apple Health list for Washington State Medicaid, you have to have failed 2 other drugs in order to qualify for it. And so it's still somewhat of a barrier from a cost perspective. But I think moving forward, this is a drug that will probably be in higher use. And certainly if you have a patient who has all these comorbidities with renal dysfunction, hyperkalemia, and proteinuric renal disease, there's a good chance they have a nephrologist as well. So if you have a primary care patient who has a nephrologist, communicating with them about potentially starting this drug is a good thing to have on your radar. In terms of side effects, it is very well tolerated for the most part. It is a salt, so it can cause edema at high doses. 2 to 14%, just depending on the dose. It's just something to be aware of if someone is prone to edema. And this is just a little graphic of this, this trial of sodium zirconium. So it was a single branch trial, and not randomized controlled, double blinded, et cetera, but they did look at 750 patients who were started on it, both with higher and lower levels of CKD, and found that most people achieved normal kalemia within 48 hours or 24 hours, and almost everyone within 72, and maintained that for the entire year on maintenance dosing. So again, quite a successful drug that I think you're going to see used clinically a lot more often moving forward, except for if you're trying to order it inpatient at Harborview, look at page. So our next, anyone have any questions about that before we move on? I will take the chat box silence as no. So next case, case number 2, Mr. Tom Mato. He is a 68-year-old man. He has COPD, heart failure, hypertension, glaucoma, tobacco use, and OA. He's coming in to see you for knee pain. Says he's been eating handfuls of pills. And you are, as a great doctor that you are, you're saying, well, that's not good. You should not be eating handfuls of pills. You look at his knees, you think that it's his OA, it's consistent with your exam. So you give him a corticosteroid injection to try to prevent continued surplus medications. But because you're also an astute student who has taken many standardized tests, you also know that this is a hyperkalemia lecture, so you're going to get some labs on him. And his current labs are showing this mild hyperkalemia, 5.9. His renal function is also a little decreased from prior. And those are his medications on the side. So anyone have any theories as to what happened? It's going to be the ibuprofen, isn't it? It's always the ibuprofen. Yes, these are good. Ibuprofen, it's the devil. Nephrology. I actually think it's a very effective drug for headaches, but I shouldn't say that as a future nephrologist. So NSAIDs, not only are they bad for your kidneys and renal function, they also can cause hyperkalemia. They do this by suppressing prostaglandin-mediated renin release. So it ends up with a hyporeninemic hypoaldosteronism, so suppressing it really early on in the axis. Reduces renal blood flow as well through afferent arterial vasoconstriction, and especially if someone is already dehydrated or in a low flow state, you're going to be more prone to this. And of course, if you have CKD or heart failure or diabetes, or you're using other drugs like ACE inhibitors, or potassium-sparing diuretics, you're going to be more prone to this as well. For everyone with well-functioning kidneys, you probably will actually have some mild hyperkalemia with significant NSAID use, but it's not necessarily going to be anything particularly significant. But if someone has poorly functioning kidneys, this is something that can actually be pretty substantial. So, I mean, hopefully you're talking to your patients about who are on these drugs and who have CKD about avoiding NSAIDs, but a shocking number of patients are just not really aware of it or don't necessarily associate the ibuprofen equals Advil and naproxen equals Aleve, et cetera. So just reiterating this is important. And I think the take home is really that NSAIDs should always be used in caution with these patients. And if they have bad renal function, then of course they shouldn't be using NSAIDs. And I think that's one of the first things we learn in medical school, but just be aware of the hyperkalemia effects of them as well. Let's see. So our next case, oops. So Mr. Cashew, he is a 58-year-old man. He has persistent AFib. He's on anticoagulation. He has non-ischemic cardiomyopathy, CKD3, methamphetamine use disorder, and diabetes. And he is on your medicine service for diabetic foot infection. He's going to require a TMA with the ortho team because he has a non-salvageable foot, and you can see his emission labs there. So just of note, some reduced renal function, mildly elevated BUN, bicarb's pretty normal. So you are doing an excellent job with managing him, and he's very stable. And this is a summer at Harborview, so the ortho team is very busy, and his surgery is just being postponed over and over again. So on day 6 of admission, these are his labs. And you can see that his potassium is coming up. Coffee, so in addition to apologizing to him for being MPO for the 6th day in a row, what are you going to do next? Thoughts? Okay, well, this is a iatrogenic hyperkalemia lecture, so you're going to look at the medications, and you really, whenever someone's having high potassium in the hospital, this is the first thing you should be doing. So these are the medications he's on currently. He's on insulin, metoprolol, gabapentin, meropenem, Tylenol, heparin, Torva. And you are holding his metformin, lisinopril, apixaban, and aspirin. I see in the chat, echo heparin, yes. So people seem to think that heparin might have something to do with it. And I think you would be correct. Of note, he's on a couple medications as well that might put him at a higher risk, including his beta blocker. So heparin is another medication that is somewhat underappreciated, I think, in terms of its effects on potassium. It works by inhibiting aldosterone production. likely through reducing the number and binding capacity of the AG2 receptors. And the effects of it are usually seen about 4 to 6 days after therapy initiation. And approximately 7 to 8% of people will develop hyperkalemia on heparin. You can have a pretty significant increase up to 1.7. And that can be with IV or subcutaneous dosing of heparin. And that can be with therapeutic as well, or with prophylactic as well, not just therapeutic. Now, most people who have a normal GFR to begin with are going to compensate appropriately. They'll increase renin production, and so potassium levels will remain approximately unchanged. Whenever you have a patient who has a reduced GFR to begin with, like Mr. Yu in this particular case, or has diabetes, or is on therapy for a longer time, or is on other drugs that can increase potassium, they're going to be at higher risk. This effect will stop after the discontinuation of heparin, usually within 24 to 48 hours. So this is something to really be cautious with. A lot of times we end up with these patients on the inpatient side who are just on heparin drips kind of indefinitely, waiting for surgery, or you're bridging them to warfarin or something of that nature, and you're on days and days of heparin. That the risk of hyperkalemia in these patients is not necessarily that small. And a lot of these patients, if they're on a heparin drip, are probably have some other predisposing risk factors for hyperkalemia development, including low GFR to begin with, heart failure, and the use of beta blockers, the use of ACEs and ARBs. In this case, it was being held because he was going to go to surgery, but a lot of times these patients will be on RAS inhibitors. So be cautious with this. And in the outpatient setting, if you have someone who's on enoxaparin for a DVT, you should be thinking about whether they are at risk for hyperkalemia and monitoring those labs as well. And we'll just go back to this diagram here. The big purple arrow is showing where heparin is working. So at the level of aldosterone production. Okay, so case 4, we have Miss Zoe Keeney. She's a 67-year-old woman. She has type 2 diabetes, CKD3 with albuminuria, hypothyroidism. She's just presenting for routine follow-up. She was seen at urgent care 4 days ago for a UTI, for which she was prescribed an antibiotic. And her UTI symptoms have largely resolved, and she's otherwise feeling pretty well. Her home medication list is glargine, Lispro, metformin, lisinopril, and levothyroxine. So just a routine follow-up, you attain her basic monitoring labs, demonstrate the following. Her baseline creatinine is 1.2. What else do you want to know? Which antibiotic? Yes. Steve wants to know which antibiotic she's on. The name of the antibiotic was, that little white round pill. People never know. But yes, I think you all are getting to the right point, which is that this is probably related to Bactrim or trimethoprim sulfa. So trimethoprim sulfa acts by increasing aldosterone resistance. It competitively inhibits the epithelial sodium channels and inhibits the sodium potassium ATPase in the cortical collecting ducts. And it actually has quite substantial prevalence of increased potassium, anywhere from 76 to 100% of patients. So that's a lot. Again, most people who are otherwise have normal GFRs are not necessarily going to have any really horrible side effects from this, but anyone who has a baseline potentially decreased GFR or is on ACE inhibitor or ARB is going to be at much higher risk. And there's actually one very large study of 440,000 patients who are on ACEs and ARBs, and they had a 7 times increase in their hospital admissions for hyperkalemia if they were prescribed Bactrim for a UTI. So that is not insubstantial, as you can see, actually quite high risk. And this is just where it's acting there at the level of the sodium channel on the luminal side, the ENaC channel. I think Risk factors for this, like I said, are already having kidney disease, being on other offending meds, being elderly. So if you have elderly patients who are on these medications, which is probably a fairly substantial number of them, avoiding Bactrim is really important, if possible. So the other note, and obviously you can't always do that, but if possible, don't run to trimethoprim as your first choice if you have the option. It's become a little harder now as fluoroquinolones have kind of fallen out of vogue for UTIs, but again, looking for other options when possible. And just a note about trimethoprim too, it also causes a rise in creatinine because it decreases creatinine secretion through organic cation transporters. That is actually a false rise in, well, it's not a false rise in creatinine, but it's a false reduction in GFR. So anyone you put on Bactrim is going to have a slight increase in their creatinine, and that doesn't necessarily mean they're having a true AKI. So don't freak out if that happens, but if someone has baseline CKD, you do have to be more careful. So again, only use it if you really need it. Be very careful if you're using other potassium-affecting medications. And a small creatinine bump is expected, but if it's greater than about 0.5, you want to think about other causes, including drug-induced AIN with the trimethoprim. Okay, so we're going to go through a few more drugs. These are not in case format, but just some other important drugs that can affect your potassium. So other medications that increase your aldosterone resistance. So a big one, I'm sure you're all aware of, is spironolactone and eplerenone. So these actually block at the level of the mineralocorticoid receptor. So they decrease the renal excretion of potassium. Might also have some effect on the GI secretion of potassium. You're usually going to see the biggest effect within 10 days of drug initiation. And again, higher risk of life-threatening hyperkalemia if they're used in combination with other drugs, but you're probably going to be hard-pressed to find very many patients that are on these drugs that are not on other medications that are affecting their potassium. Most people on spironolactone for heart disease are also going to be on an ACE or an ARB. So something to be cautious of, should be checking these potassiums frequently in these patients. There is a mortality benefit in heart failure and cirrhosis, as everyone here, as I'm sure you know. So they should be on these medications if they're indicated, but just be cautious with potassium. In some cases, again, it can be limiting what your dosages are allowed if their potassiums are getting too high. Kind of interestingly, when it came out that these medications had a mortality benefit in heart failure and started coming into much higher use in the 90s and early 2000s, a retrospective study looked back at the rates of hospitalizations for hyperkalemia, and they went up by a factor of 5 in these heart failure populations. So even though at the beginning the studies kind of showed out it's not a huge effect of potassium, the initial studies weren't really looking at patients who had baseline CKD. There are a lot of exclusion criteria. So in practice and in clinical practice, you're going to see a lot more hyperkalemia induced from this drug. So just cautious, monitoring these patients closely until they're on stable dosing is very important. Another medication in this category, amiloride and triamterene. I don't think you're going to see this medication very frequently in practice. I think I've seen amiloride just a handful of times. It works similarly to trimethoprim, actually, blocks the luminal sodium channels. So it reduces that negative potential that leads to potassium secretion. If you do see it, it will probably be in combination with hydrochlorothiazide. And there are some small studies that have shown that it can cause hyperkalemia, again, by a similar mechanism of Bactrim. I don't think this is a drug you're going to see frequently, but if you have someone who maybe has complex hypertension or complex renal disease, you might see it, and just be aware that that's how it works. And then another category that we haven't really discussed too much is the alteration of transmembrane transport. So a certain number of medications actually cause higher potassium by increasing the intracellular movement of potassium to extracellular space. So beta blockers are probably the biggest category of medications that do this that we use frequently. As you might know from our ORCA power plan, given a beta agonist for hyperkalemia, drives potassium intracellularly. So beta blocker does the opposite. Usually it's a pretty modest effect and not necessarily going to be clinically significant in the majority of your patients. But if you have someone with ESRD especially, it can actually increase it pretty substantially. So potassium can go up by as much as 1 millimole per liter. So that decreases that activity of the sodium potassium pump. Another proposed mechanism is that because of the beta blocker effect, your sympathetic nervous system is suppressed, which suppresses the release of renin. So a couple methods that this is working. And the effects of it can be a bit prolonged in CKD patients, especially renally clear beta blockers like atenolol. I don't think we're using a lot of atenolol anymore, but you might find you have some patients who've kind of been on atenolol for 20 years that you haven't taken them off. So if you're having problems with hyperkalemia in some of these patients, thinking about at least changing your beta blocker to one that's not renally cleared can be helpful. And as we've kind of been going through these cases, almost all these patients were on a beta blocker because it was indicated for their heart failure. So just thinking about the fact that that's probably having some modest contribution to hyperkalemia in these patients is important. And then digoxin, another drug that we're probably not seeing a lot of anymore, although from the cardiology service, you'll still see it used not infrequently for AFib. So hyperkalemia with digoxin is really only seen when it's at toxic levels. So if someone is not toxic, they should be okay. But this is a dose-dependent inhibition of sodium potassium ATPase, so similarly blocking the secretion from the intracellular to extracellular space. And ESRD patients are, again, most at risk. You can use digoxin in ESRD patients, and it can be very effective for AFib, but you have to adjust the dose appropriately. Speak to your neighborhood pharmacist about that. If you're considering starting digoxin, anyone with renal failure, even a AKI or anything that's decreasing their GFR, to make sure you're appropriately dose reducing it. And this is just kind of going back to this slide, which kind of shows many of the different places these drugs are acting. You can see beta blockers up in the top left there in a similar place to the NSAIDs. And I don't think digoxin is actually on this. And then amyloride and tramtaurine down by the trimethoprim and pentamidine. You can see there's a few other drugs listed here that I didn't really discuss. Let's see. And so things like, calcineurin inhibitors, which you might see in transplant patients, which are not necessarily uncommon patients at the University of Washington. Those can also cause hyperkalemia. Direct renin inhibitors is not a drug we're really seeing much in clinical practice currently. And there is a whole host of other medications that have been associated with hyperkalemia. So just because it's not on the kind of common list doesn't mean it's not associated. So whenever you're seeing hyperkalemia in a patient, the first thing to be doing is to look into the medication list, because usually that's going to be contributing in some way. And then that last category that I mentioned earlier on in the talk is potassium-containing drugs. So this is pretty rare cause of severe hyperkalemia, but it can be associated. I think someone just asked about if there's any herbal supplements. I don't know specifically about herbal supplements, but salt substitutes, like I think the Mrs. Dash, whatever, has potassium in it instead of sodium. So if patients are on salt, using a lot of salt substitutes because they have heart failure, they might actually be getting a potassium load from that. So being aware of that. Less commonly, you'll see potassium citrate for urine alkalinization in certain cases can cause elevated potassium, and PenG has actually been associated with it as well. Again, not really in people who have well-functioning kidneys, but in general, dietary potassium is not as much of a driver of hyperkalemia because most dietary potassium is in the form of potassium phosphate. as opposed to potassium chloride. But if someone is using a lot of salt substitute, then they might be inadvertently driving up their potassium. And like I said earlier, these kind of renal diets and low potassium diets, there's a lot of ongoing controversy and some studies about whether or not these are the best options for patients, because when you eliminate potassium from someone's diet, you eliminate essentially all fresh, healthy food, and whether or not that's actually a good option for most patients. There's been some evidence that it might not be, and we might be doing more harm than good by telling people to eliminate fruits and vegetables for potassium concerns. So people should be aware of potassium levels in their foods and thinking about it, but it's not, there's, like I said, it's not an absolute recommendation anymore. And in practice, the kind of traditional renal diet is extremely difficult to adhere to. So is that true for ESRD on HD as well? Yeah, so again, this is sort of an ongoing discussion about whether we should be recommending very low potassium diets for patients on HD. It depends, it's very patient specific to begin with. If someone's really prone to hyperkalemia and you're having trouble managing their potassium, that might be something that you're thinking about. But if someone's potassium is generally staying in a normal range and they're on dialysis and being dialyzed appropriately, then they don't necessarily always need to be on these ultra low potassium diets. So again, it's like a kind of a case-by-case basis at this point, and it's a topic of ongoing discussion and research, so stay tuned. But this whole idea that people should be on these minimal potassium diets is falling a bit out of vogue because they're really not sustainable, and people end up eating less healthy food on them. So in terms of take-home points on the management of hyperkalemia, should be obtaining baseline potassium levels and creatinines before starting any of the therapies that we discussed before. Rechecking that BMP in a couple of weeks, 1 to 2, usually on the earlier side if possible. Reviewing medications prior to starting new therapies, because as you can see, all these medications that are used together affect potassium, and that can be a synergistic effect. Titrating your medications slowly and using diuretics when possible if your volume status and blood pressure allows, to help offset the effects of elevated potassium, and the potassium lowering agents when appropriate. So patiramir, especially, covered in Medicaid, and the zirconium to a lesser extent, are real options for patients. And we shouldn't just be stopping their ACE inhibitors and ARBs because we're afraid of hyperkalemia in patients who have indications for them. So if it's possible at your clinic to start them on a potassium binder, that is a great option. And it's something that I think will become more common in the future. It's being used in nephrology clinics pretty frequently, but it's not off the table for patients in your primary care clinics as well, if you think there's an indication for it. And this is just a little run through up to date. I'm not going to really go through it. It's just as a reference for what to do with acute hyperkalemia and how to think about that. So thank you. And thank you to Leah Hazley for, I asked her what she thought, what topic in nephrology she wanted or felt like residents should know more about, and she suggested iatrogenic hyperkalemia specifically. So thanks to her for the suggestion and for looking at these slides and making sure I wasn't telling you things that were blatantly false. And some references. Any questions? Reuben, my dog, he actually, I turned our gas fireplace on, so now he is lying in front of that and not bothering me anymore, so it's helpful. All right, well, thank you for listening, and thanks everyone for, obviously there's already a lot of knowledge about this, which is great, and feel empowered to use potassium binders. They are great drugs, and they are only going to become more in use moving forward.
Awesome. Thank you so much, Karen. And thanks everyone for joining today. We have a little bit shorter meeting, so log off and feel free to use that extra time for whatever you see fit. Thanks, guys. See you next week.